Hello and welcome to our new topic. Today's topic is about painkillers or analgesics which do not belong to opioid drugs. One of these drugs, called acetaminophen or paracetamol, is the most commonly used painkiller in the world and is an over-the-counter medication. Interesting, isn't it? So let's start. The learning objectives are shown. By the end of this lecture, you should be able to explain how non-opioid analgesics work, including their mechanism of action and receptor selectivity. We will examine their pharmacokinetic profiles, enabling you to appreciate why certain agents are preferred in particular clinical settings. Additionally, we will review their therapeutic uses, adverse effects, and the principles behind managing toxicity, particularly acetaminophen overdose. Very often, inflammation, pain and fever go hand in hand as part of the pathogenesis of a disease. Hence, we need drugs with anti-inflammatory, analgesic and antipyretic effects in many conditions, to reduce inflammation, pain and fever. The non-steroidal anti-inflammatory drugs are the only example that can reduce all three. Acetaminophen and nefapam occupy an interesting space. They provide analgesia without the prominent anti-inflammatory or antiplatelet activity seen with NSAIDs. This makes them valuable in patients who cannot tolerate NSAIDs due to gastrointestinal, renal, or bleeding risks. Acetaminophen, also called paracetamol or APAP, is one of the most widely used over-the-counter analgesic and antipyretic drugs. It has no meaningful anti-inflammatory effect and does not impair platelet function, which differentiates it from NSAIDs. It is the active metabolite of phenacidin, an older drug withdrawn due to nephrotoxicity. Adult dosing should not exceed 4 grams per day, while the toxic threshold is around 7.5 grams. In children, doses are weight-based, and toxicity similarly depends on exceeding recommended limits. The precise mechanism of acetaminophen remains incompletely understood. It appears to weakly inhibit COX-1 and COX-2 but exerts its significant antipyretic activity centrally, at the hypothalamic COX-1 variant often referred to as COX-3. This central mechanism explains why acetaminophen can cause hypothermia, unlike NSAIDs, whose effects depend on peripheral COX-2 inhibition. Emerging evidence suggests acetaminophen may indirectly activate CB1 cannabinoid receptors by increasing endogenous cannabinoids, contributing to its analgesic action. Acetaminophen is ideal for mild to moderate pain and fever in conditions where inflammation is not the dominant feature. It is especially suitable when NSAIDs are contraindicated, such as in patients with peptic ulcer disease, coagulopathy, gastritis, renal compromise, or platelet dysfunction. Unlike aspirin, it is safe in pediatric viral illnesses because it has no association with Reye's syndrome. It is also used in gout, as it does not influence uric acid excretion unlike NSAIDs. At therapeutic doses, acetaminophen is generally safe, but mild elevations in liver enzymes may occur. With larger doses, patients may experience dizziness, excitement, or disorientation. The real concern arises with overdose, due to toxic metabolites that can cause severe liver injury. After absorption, acetaminophen is mainly conjugated via glucuronidation and sulfation as shown in blue. A small fraction is metabolized through the cytochrome P450 pathway, particularly 2 × 10⁻⁴ cypriot pounds, into the toxic metabolite N-acetyl parabenzoquinone imine or NAPQI. Under normal circumstances, NAPQI is neutralized by glutathione. However, in overdose situations, conjugation pathways saturate, shunting more drug into the cytochrome system and producing excess NAPQI. When glutathione stores fall below about 30%, hepatotoxicity sets in. Chronic alcohol use induces or increases 2 times 10 to the 1 cypriot pounds expression and activity, meaning patients with a history of chronic heavy alcohol consumption who suddenly stop drinking are especially vulnerable. Acetaminophen toxicity causes a characteristic pattern of centralobular and midzonal hepatocyte necrosis, with relative sparing of periportal areas. This pattern reflects the zones where 2 times 10 to the 1 cypriot pounds activity is highest. Recognizing this pattern helps in differentiating APAP toxicity from other causes of acute liver failure. Management begins with early decontamination. Gastric lavage is useful within the first 2 hours, while activated charcoal is effective in binding drug that remains in the GI tract. In severe cases, extracorporeal techniques like charcoal hemoperfusion may be considered, though their effectiveness varies. The mainstay of treatment is N-acetylcysteine, NAC, which replenishes glutathione stores and directly detoxifies NAPQI. It is important to note that NAC is most effective when initiated within 12 to 24 hours after ingestion. Serum acetaminophen concentrations measured 4 or more hours after ingestion can be plotted on the Rumack-Matthew nomogram to determine whether NAC therapy is necessary. This tool guides clinicians in predicting the risk of hepatotoxicity and planning appropriate treatment. NAC acts by replenishing glutathione, neutralizing NAPQI, and allowing the liver to recover. It also enhances sulfation pathways and may have additional protective antioxidant effects on the microcirculation. Treatment typically lasts 36 to 72 hours, depending on clinical response and laboratory parameters. Acetaminophen overdose is the leading cause of acute liver failure in many countries where chronic alcoholism is common. Toxicity is dose-dependent and produces extremely elevated aminotransferase levels, often exceeding 3,500 IU per liter. NAC remains the only effective antidote. Early diagnosis and timely treatment are crucial for preventing morbidity and mortality. Nefapam is a centrally acting non-opioid analgesic used for moderate to severe pain. Previously known as phenoxyzine, its exact mechanism is not fully understood. It increases pain threshold by inhibiting the reuptake of monoamine neurotransmitters serotonin, norepinephrine, and dopamine, similar to an SNDRI class effect, and may also reduce glutamatergic transmission. These combined actions provide analgesia without opioid receptor activity. Nefapam can produce anticholinergic and sympathomimetic effects, which may compound with other similar drugs. Common side effects include nausea, dry mouth, dizziness, and urinary retention. Less commonly, patients may experience insomnia, hallucinations, tachycardia, or angina. Rarely, it may cause benign pink discoloration of the skin or erythema multiforme. Careful patient selection and monitoring are important when using Nefapam, particularly in those with cardiovascular disease. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!